Good evening, everybody. Welcome to our second Oxford and Cambridge Society Malaysia webinar. The webinar this evening is obviously particularly important given the concerns that a lot of us have about the coronavirus. And we're all slightly infuriated by the myths that are going around. So we thought it would be really helpful for everybody to have two doctors to come and talk to us. As with the one with Professor Jomo on Friday, please type any questions that you want to ask them in the chat in YouTube, and we will then forward those questions to the doctors. So first of all, I want to introduce our moderator. Many of you know him very well. Mark Disney is a past president of the Oxford and Cambridge Society. He's also deputy head of the sixth form at College Tunku Jaffa. He's moderated many Oxford events for us, also at KTJ and Sunway and LSE. So we're in safe hands this evening with Mr. Disney. So I'd just like to introduce our two doctors that we have with us. Dr. Usha Rani George is a chest physician at Sunway Medical Centre. She graduated from Manipur, India in 1988 and MRCP London in 1993. She gained her master's in respiratory medicine from Imperial College in London in 1998, and she's been with Sunway Medical Centre since 2000. Our second doctor is Dr. Tan Lian Huat, who is an infectious diseases consultant also at Sunway Medical Centre. He graduated from HKUM in 1994 and completed his master's in internal medicine in 2001. He then specialised in infectious diseases also at UM, and he joined Sunway in 2008. So I'd like to ask Mr. Disney to start with the first series of questions, and then we'll jump in with your questions as we go through the interview. So welcome, Usha. You said you'd like to be called Usha, so welcome, Usha. Welcome, Dr. Tan. Thank you very much for coming with us, for being with us this evening. Okay, over to you.
Okay, thank you very much, Emma, and welcome to both of our doctors. I suppose when you think about bad news, it's always good to get a second opinion. So we are delighted that we've got two very eminent Malaysian doctors with us this evening. In case we have some issues with connectivity, I'm going to ask a series of questions to each of you, and I'd like to begin, if it's okay, with you, Dr. Usha, and then we'll come on to Dr. Tan in a minute or two. But could you first of all begin by just explaining to us your specific role at Sunway? I understand that you're a chest and lung specialist, and perhaps tell us something about how your daily routine has been affected by this rather unprecedented pandemic.
Thank you, Mark. Thank you, Emma, for the kind introduction. So Sunway Medical Centre is a private hospital. We are a 600-bedded hospital. Now in Malaysia, as far as actual treatment of COVID patients, they are referred to designated government hospitals. Generally, in private hospitals, we don't treat. But certainly, being a premier hospital, and as a chest physician practicing there, my practice has changed dramatically in the last 100 days. We formed a task force and started screening patients. And certainly in my particular profession, being COVID, naturally a respiratory pathogen involving the lung, naturally patients present with constitutional symptoms, respiratory symptoms. And what I've done now is I've put COVID high up on the list of my differential diagnosis. Simply the fact that certainly we've seen it's a master mimicker. Initially, we recognize with respiratory symptoms, but as the disease progresses, we realize that it involves all the systems. It can present as a gastroenteritis, it can cause skin manifestations, it can cause neurological symptoms. So, and the other thing that we found recently is that it's made life more difficult because it can coexist with other infections. For example, dengue being endemic in Malaysia. Now, we've had patients whose dengue serology negative presents with fever, but as we treat them, we find that the fever lasts longer than usual. So then our antenna comes up, and lo and behold, when we test them for COVID, they are COVID positive. So these are the difficulties that have come into practice now. The second, I think, major change is because it is an infectious disease. I've also particularly put emphasis on using PPE, what is known as personal protective. Instead that we mask, we glove, essentially, and especially when I admit the patients, it is Sunway's prerogative to admit them into isolation wards. Certainly, we have to protect the healthcare workers. Also, in the building environment, we have to make sure that the disease is contained and does not run amok in the hospital.
Okay. I mean, interesting that you say that. I mean, how has this affected your regular practice? I mean, given this, I won't say obsession with COVID, but I don't know if it's a paranoia or how justified it is, but you must have lots of people coming with, you know, in the ordinary course of business with various issues. Has COVID been a real kind of a drag on your regular work?
I think one is volitional in that front, in a sense that we've encouraged patients who are stable and who do not have acute medical problems to stay away from the hospital. And we are starting telemedicine. It's in its infancy, it has its own problems, but we are trying to treat and manage stable patients by keeping them away. In terms of, in fact, recently there was a New York headline that said, New York Times headline, where have all the heart attacks gone? And it can be, ironically, it's eerily quiet in hospitals now. Now, we do not know whether it's a natural tendency for patients with illness to stay away. Now, that may not be very good because even if they have heart attack symptoms, if they stay away, then they may present much later with problems. And also, we have sort of done away with elective operations, elective procedures in terms of scopes, because you know that scopes will cause patients to cough. Cough will increase aerolization of bugs, and that again would be detrimental to the work and the healthcare workers. But then again, all said and done, we also have to look on the flip side of the coin. By keeping people confined, there are new problems. I mean, there might be mental health problems, domestic problems, substance abuse problems. So it's difficult all along.
Yeah, thank you. That's a really interesting perspective. Dr. Tan, could I turn to you for a second? Could you give us some idea about the range of symptoms in terms of how they present themselves and the varying degrees of severity that you are seeing?
You're referring to COVID-19, is that right?
Yes.
Yeah, because I can't hear what Usha said earlier because, for some reason there's some technical issue. So I have no idea what she has said.
Dr. Usha basically explained that one of the big issues is patients with existing illnesses are shying away from coming to hospitals.
Yes, that's true.
Things are rather quiet, quieter than they would be, and that there are all kinds of knock-on effects with this crisis. But what kind of situation are you experiencing over in some way?
We are not the designated hospital to treat COVID-19, but because we do play a role in battling with this outbreak, because we need to identify patients and make a diagnosis and then send them to the designated hospital if they fulfill the criteria for COVID-19 or PUI, person under investigations. So in that aspect, we do play a role, especially our frontliners, our MOs in the medical tent. They have been helping us in a big way because they are the first one who will attend to the patients. So basically, we have come up with some guidelines for them to look up for possible potential patients. So the common symptoms that we want them to pay attention to will be fever, sore throat, cough, and in a more severe form will be those who may present with short of breath. And in small number of patients, they may present to us with fever and diarrhea or abdominal pain. And this is not uncommon because I think there were one or two private hospitals uh, other than Sunway that were caught for that kind of cases, initially presented with gastrointestinal symptoms, which later on turned out to be COVID-19. So these are the not so typical presentation, but a well-recognized presentation. But certainly there's a larger number of people with very mild symptoms and all without any symptoms. We have heard people with loss of smell, loss of taste, and in fact, there are quite a few people who returned from UK or other countries that presented that way. The initial wave of this COVID-19, there was not much description about the symptoms, but subsequently, when the disease spread to other countries, then people beginning to recognize this as another symptoms. And recently, we also were informed by our colleague in the Europes that there are many people who present with skin manifestation like rash, petechiae, or some even with the embolic kind of phenomenon, the vascular kind of disease of the skin. So those are interesting manifestations which were not recognized in the beginning when the outbreak happened in China.
Yeah, it's interesting you say that, because that's actually what Dr. Usha mentioned as well. I hadn't realized that a presentation of symptoms involved things like, gastrointestinal problems or skin problems. It's the first time I'm hearing that. Is this simply because we don't know enough yet about the illness and the disease?
Yes. In fact, in our region, this will pose a greater challenge for us because, as you all know, dengue is endemic in our country, and dengue can present with GI symptoms, gastrointestinal symptoms.
Right.
Dengue can have skin rash, and all this, presentation in COVID-19 can mimic dengue. So it makes our life even more difficult.
Yeah, I was going to say, so essentially, until we have a fast and really effective testing system, you guys are, in a sense, blind, right? Because you could have many, many different kinds of illnesses, all presenting with the same symptoms.
Yes. So because dengue is so common, and to make things more complicated, they have cross reactions in terms of the dengue testing for COVID-19. I think Singapore reported 2 cases in the literature where initially tested positive for dengue IgM, IgG, and then later on turned out to be COVID-19. So that is really a huge challenge for us, and it's very, very risky for frontliners and also for physicians handling dengue cases in this country.
Yeah, that must be. That's I hadn't really thought about that. Dr. Usha, if I could just turn to you again, given your own particular specialism, could you give us some idea of what COVID, what this pathogen actually does to the lungs, and why it's so dangerous compared to, say, even severe forms of flu?
Sure. Now, I think this is important because it's important to understand what the virus is and how it gets into the lungs and the effect it has to the lungs, because this has implications for treatment. Now, a virus, basically, there is still controversy as to whether it's living or non-living. It just exists. It's a fleck of genetic material. I mean, just to give you an idea, it's 10,000 times smaller than a speck of salt. So genetic material is surrounded by a lipid protein with an envelope. Now, what happens is it's in existence, and it can only replicate, survival of the fittest, if it finds a cell to lodge on. So now, it's been known that there are certain receptors in the throat. I particularly put emphasis on the throat, the lungs, and these are called ACE2 receptors. Now, these receptors physiologically are important for normal functions of the body, angiotensin converting enzyme 2. They are there for control of blood pressure, etc. So they basically they are a cell and they've got sort of a gate. Now, for some reason, COVID-2, what it's been done is been able to get a key, and that key, they've managed to unlock the gates of ACE2 receptors. So by this means, they attach themselves and get into the human lung cell through the ACE2 receptor. But in any individual, this is like an invasion. The enemy is approaching. So the human lung cell is not going to stay quiescent. It's going to say, look, my immune system has to it sort of hyperreacts. So you've got this T cells and B cells. Now these T cells will send off soldiers, and they are in the forms of what we call cytokines. They are messengers, and these will carry ammunition. The main crux of the problem is we do not know why some of these T cells overreact. So rather than carrying simple ammunition, they come out with missiles. And what happens is these missiles will sort of attack the viruses, and basically the lung and the human body is basically the battleground. So basically here, the patient and the lung cells are leveled while being saved, something like the Avengers. So basically the defense is, apart from eliminating the virus, is destroying the lung through inflammation, the immune system, T cells, inflammatory mediators, and the lung cells get damaged. So when the lungs are damaged, you know, it's an organ where you get oxygen, you get low oxygen, and basically this will herald multi-organ failure. And it can be devastating, leading to death.
Are the lungs like one of, I mean, I forget which, is it the liver? I mean, some organs can regenerate. I mean, if somebody has COVID, even seriously, but then recovers, what kind of long-lasting damage may there be to the lungs?
Absolutely. The lungs, they're very resilient organs. But the thing is, like any healing process, when you injure yourself, you heal with scar tissue. So similar with the lungs, after acute lung injury, the lung will lay down scar. So depending on the amount of lung scar that's there, you might be, I mean, if there is minimal, you might be back to normal, but generally you'll be left with residual limits, like for instance, decreased effort tolerance, your breathing will not be what it was, and certainly in the elderly it can be detrimental.
Okay, thank you. Dr. Tang, can I turn back to you for a second? One thing that I think has puzzled a lot of people is why some people seem to be much more badly affected by this than others. I mean, initially when the pandemic began, we were told, or the understanding was that it was affecting those who were much older, 60, 70, 80 plus, or people with serious underlying illnesses. But then we've heard of younger people catching it and dying, people even in their 20s and 30s. We also hear about A, B, and C strains. I wonder if you could just explain why some people seem to present more severely than others.
We still do not know a lot of things about this disease. One of the things that they observe is pretty much to do, those who present with severe disease, pretty much to do with the immune response. Because they realize that for those who deteriorated very fast, they have this condition called cytokine storm, where you have lots of cytokine being released from the in your circulation system, and that results in lots of complications, including you develop hypoxemia, meaning you become more breathless, you need ventilatory support, and at the same time you can have vascular problem, because it seems not apart from lung, you also have this vascular involvement. There are changes in the endothelium of the vessels that can result in either a thrombosis or either inflammatory response in those areas. And also that says the cytokines itself, apart from affecting the lung, it also can affect other organ function as well. And if the vessels are affected, the small vessels or larger vessels, that can also cause poor vascular supply to those organs. That can also result in organ dysfunction. So lots of issues over here and lots of things that we still not very clear. But the consistent findings is for those who develop more severe form of disease, often they will have this cytokine storm before they go into multi-organ failure.
I see. Interesting.
Yeah.
We're also hearing reports, and again, I don't know how much of this is fake news and how much of it is real. I guess we don't have the data yet, but we're getting reports from the UK and from the US that minorities, BME, in a black and minority ethnic in the UK, and black people, especially in the US, seem to be affected and even dying at higher rates than, say, whites are. Is that true? Or am I misreading that data?
I mean, from what we could read from the news and reports, the issue is a bit more complicated. It's not just a disease alone, but that involves the socioeconomic status of that particular minority group. And often, and as far as we know, a lot of all these people may have pre-existing underlying medical problems like hypertension, diabetes, and whatnot, because the proportion of people having those underlying disease are much higher than the other ethnic group. So to make things more complicated, is if they have a poorer socioeconomic status, they may have not be able to access to medical attention early enough, and by the time they presented to the healthcare system, it will be too late, and in a more severe form of disease before they can do anything.
Yeah, I mean, in Malaysia, of course, we are, everything is racial. Data and so on is collected with IC cards and race in mind. Are we seeing that kind of differentiation in Malaysia? Are certain groups more prone to this, as far as we're aware?
Well, we would like to know in more details, but unfortunately, I think that the data that presented to us or reported to us didn't give us the more details, especially in terms of the ethnic group. So we do not know in details about all these things, and we won't be able to analyze the situation unless the Ministry of Health, they have their own internal analysis. Then later, if they were to publish it, then they will have a bit more understanding. At the moment, we don't have such data.
Yeah, I suppose that we don't have enough deaths to have any meaningful data on that, really. I mean, I don't know what the figures are at the moment in Malaysia, but they're still very low compared to other countries.
Yeah,
it's
about 1.66%. Yeah.
What, 1.6?
1.68%. It's less than 1.7%.
Right. That's
based on the current data.
Yeah, that seems very low, doesn't it? Okay, thank you, Dr. Tan. Dr. Usha, can I turn back to you? I guess the obvious question, and it's one that we're seeing in the newspapers every day, but what should people realistically be doing to guard against this outbreak? I mean, just ordinary people, me and my family and my friends, what should we be doing realistically?
I think certainly the principles, certain countries, we should take the examples of certain countries who've had success in managing this disease. And let's take Korea, for instance. Now, they basically had an MERS outbreak in 2015, and they lost 100 over people. But they did sit back. So they learned from it. So similarly, when they heard of the first death in Wuhan, even before a case hit their shores, they set things in motion. And basically, the whole idea was to diagnose. So they literally manufactured thousands, hundreds of thousands and millions of test kits that you and I know now that well-developed countries are lagging. And the other thing, right? And the other thing, of course, is apart from testing, they came up with apps for phones. But certainly, I mean, in an Asian population where freedom is often sacrificed over the well-being naturally, so all the citizens their phones had apps. so that if there was a case that's positive, immediately it will bleep on their phone. And all surrounding contacts would report to the nearest authority and self-quarantine themselves. And that was amazing. So basically what they did was test, isolate, and social distancing, quarantine, a lot of sacrifice, but they realized that they could only overcome this for the good of the society. The other very simple, the other controversial is to mask or not to mask. Now, I don't think I need to go further when you see Dr. Tan here wearing a mask. So obviously, you know where we stand.
Yeah.
So, yeah, I mean, the thing is, it's, again, even before the pandemic, the Japanese, they would mask because it was civic conscious of them. They felt that if they had infection, they did not want to spread it to others. And it is very well known with the COVID that they are infectious in the asymptomatic stage. And this is how they're propagated to the way it is. So basically by masking, even if you have COVID, but you don't have symptoms, you are decreasing the rate of infecting others. And I think these are very simple solutions that the countries that have got on top of the disease has practiced.
Yeah, I was listening to BFM late this afternoon, and there was the report or the interview with Noor Hisham, the DG, giving his daily briefing, and he said that it's a 30% chance of getting infected if you are in close contact with somebody who carries the disease. Does that compare with other kinds of illnesses? That kind of infection rate, 30% seems quite high.
Right. So that's interesting, because let's compare it to the influenza virus. And that's one of the myths, is that why worry? COVID is just like influenza. Well, I can say now that it absolutely is not just like influenza. And this is the very thing that you brought up, Mark, about how infectious is the COVID-2. In influenza, generally, we know that there is something called, I'm sure you've heard, the new terms, and this is called the replication, or the R0. The R0 is an epidemiological term, and it means from one person, the number of people that you infect. And it is well known that the R0 for influenza is roughly 1. And of course, depending on the situation, if you were in Malaysia or if you were in, for instance, like the Diamond Princess cruise, the R0 varies. But generally, the R0 for COVID-2 is roughly 2.5. That means for every one person, you spread to 2.5 people. So imagine how fast it sort of exponentially. You spread to 2 people will spread to 4, 4 to 8, 8 to 16. And if you're late, if you're caught napping, and this may have happened in metropolitan cities like London and New York. And so certainly the infection rate is at scary levels.
Yeah, I mean, it was I think baffling to a lot of people that you look at countries like Kerala. You mentioned Korea, South Korea, but of course Kerala has had remarkable success. And then you look at London, New York, you look at Spain, Italy. These are highly developed countries. Why were they hit so badly?
I think, you see, firstly, there is a problem with data. The thing is, you see, when we interpret these results, there's no uniformity. For instance, like death rates, the denominator varies because you are not testing the whole population.
Yeah.
So in terms of Kerala, when they say low death rates, again, you really need to analyze the data and see whether they've tested enough people to be able to come up with accurate incident rates. Now, the thing about metropolitan, like the whole of the US, the epicenters, it all boils down to any infectious disease. It's the number of population, the proximity. You've got 10, 12 million in New York City, and you've got crowded subways. So that is sort of a petri dish for infection. So I think apart from that, again, culture. again, we know that it's well known that obesity is a huge risk factor. And that is why when you look at New York death figures, you see there's always another myth that says the young, we are protected. It doesn't matter. Let us get infected and get natural immunity. But if you look at New York ventilated patients, 40% of their ventilated patients are aged between 29 and 40. And the reason is because of the high risk of obesity. So really, data is difficult because this is a pandemic. So you don't have, it's sort of like comparing apples and oranges. It's difficult. It's complicated.
Okay, thank you, Dr. Tang. Can I come back to you for a second? There's been so much information and perhaps even disinformation or misinformation spread around social media and even on the news. Are there any things that you've come across circulating out there that you would like to debunk now and to tell us, no, that story is not true? You must have heard all sorts of things via social media.
Just so many things that's circulating around. I don't know where to begin.
Tell us what we should tell us what we should be ignoring and not worrying about.
I think we should still stick to the evidence-based kind of practices, particularly on social distancing, particularly on the hand hygiene, because a lot of people, although been told repeatedly about this, but not able to adhere to that adequately. But they would rather believe there are other remedies that can help to prevent them from getting infected. Like, for example, taking certain concoction or decoctions, for that matter, or some people may even wear certain gadgets that will been labeled as able to kill the virus and prevent them from being infected. So those are not proven kind of practices, and more importantly, I think we need to stick to the science and the evidence that we have gathered so far, and to protect ourselves.
Perhaps I could just quickly ask you, one question that's just come in, I see it on the stream from Yu Young, who's one of our members, and she says, around the world, the data seems to be suggesting that far more men are dying than women. Is that the case? And if so, why do you think that might be?
I think the initial reports, mainly the men was predominantly affected, and then later on, then the women catching up with that. But I don't really know the details of it because we don't have adequate data to look at it in more details. Obviously, when the first hit population were among the male, obviously you see more death from the male category. But subsequently, when more women affected, then that's different scenario altogether. So I guess we need to see more analysis of those data. Then only we have a clearer picture.
Yeah. Dr. Usha, do you have any thoughts on that? Because I certainly remember with the Wuhan, when the Wuhan data came out, one of the excuses or one of the reasons that people were giving is that it seemed to be affecting a lot of older Chinese men, the vast majority of whom still smoked, even into their 60s and 70s. Could that be a factor?
Clearly, I think it's been shown that certainly smokers are very high risk.
Oh, and
again, simply because smoking is associated, it damages the epithelium, so the local immunity is poor. So you'll not be able to mount the usual immune response when the virus infects you.
Okay, interesting. And can I just stick with you? Talking about treatments, right? Obviously, this is something that's that everybody is thinking about now. We are developing the vaccine and so on. What are there any possible treatments at the moment? And if I had a question come in from a student called Kelvin, he said, ask her about her take on repurposed drugs, things like chloroquine and remdesivir, which I've never heard of. Are they potential treatments? Are they safe?
Excellent question. Now, firstly, I'll start off by saying that there's no proven effective treatment to date. And you see, the thing is, there's no one single magic bullet because it's a continuum of disease. It's an infection where there's viral replication, followed by the immune response, causing lung damage, and eventually supportive treatment. So I'll just, in terms of treatment, so let's talk about repositioned drugs. And of course, naturally, hydroxychloroquine, because a certain politician has advocated it.
Donald
But
Trump.
all right. But the thing is, as scientists, a lot of, because of the pandemic and the panic, a lot of these trials, what we see are pre-publication. They are not peer reviewed. So the one study that was being quoted was a French study. Now, in any trial, just to quickly, in 2 sentences, tell you what a validity of a drug trial is. Number one is you must have a control group, because you could say hydroxychloroquine worked for these 20 patients, but if the patients were not of hydroxychloroquine, would it have naturally resolved? You do not have a control group to offer. None of these studies have got control groups now. And number two, you're talking about small numbers. There's no power to the study. 26 patients in this particular French trial that's being quoted. And at the end of the study, 4 or 5 patients were not included in the final result. Now that's a big percentage of the study. And apparently, I mean, the facts show that these 4 patients ended up in ICU. And you also need to look at who conducts the trial. I mean, is it a pharmaceutical company? There may be bias, there may be gain. So you really have to take this with a pinch of salt. Now, when we talk about treatment, it's basically if you look at the science behind it. Again, why I stressed about the virus, because most of these drugs, in terms of, let's just concentrate on hydroxychloroquine, the anti-HIV drugs, and remdesivir. It is a drug produced by Gilead, and it was initially used for Ebola, but it was not effective. So what happens is when the virus gets into the cell, it gets translated into protein. And this particular stage of translation, that's where hydroxychloroquine works. Hydroxychloroquine is a very, very important drug because it's an immune modulator. It's life-saving for patients with autoimmune diseases like SLE and rheumatoid arthritis. So it also has this additional translation of the virus. And then the virus replicates through this polymerase enzyme. So this anti-polymerase is where remdesivir comes in. So there is a scientific basis to it, but we don't have the evidence yet. And we must realize that all these, when you present results without good evidence, there's a natural tendency to hoard medication. And this is dangerous because you are keeping the drugs away from patients who really need it. Then very quickly, the other group of drugs that are in trial are drugs that deal with the immune system. So as I said, when the immune system builds it up into this storm, and that kills the patient. So as an emergency measure, you need to use common things, steroids. Steroids have been used. Now we know the side effects of steroids, meaning that, you see, the thing about a virus is it's an host cell. So if you have antiviral properties, it's a double-edged sword. You can also have detrimental effects to the host cell. So in steroids, you may dampen the immune response, but you also decrease the immune response of the human cell, predisposing you to secondary bacterial infection that can cause death. And lastly, there's this group of very fancy, sexy drugs, what they call monoclonal antibodies, because these soldiers, I told you, they're cytokines, and they're labeled to them. For instance, something called IL-6. And this group that's called tocilizumab, or these are monoclonal antibodies that are used in rheumatoid arthritis. So they are also being tried to dampen the system. But the reality of this, Mark, the reality is 1 vial of tocilizumab is 5,000 ringgit.
Oof.
It's not something that you can just apply willy-nilly on everybody. And the last thing, the last important group of therapeutics is where the current controversy is flattening the curve. Why are we flattening the curve? Because we cannot overwhelm the last group where we need supportive care, where the lungs are damaged, the lung go into lung failure, the patients are gasping, they don't have oxygen. So you need to take over the function of the lung by letting the ventilator breathe for them. Now, there are two problems here. One is ventilator is very sophisticated hardware. You don't just dial on, off, and go off and as if you set a microwave. It's very complicated. So who does this sort of medicine? It is a very highly skilled profession, what we call intensivist. It takes 10, 12 years to train them. So the thing is that is what's happening, where the healthcare systems of countries have not looked into it. And when these ventilators run out and when ICUs don't have doctors, this is when we spiral down.
Wow, interesting. I mean, there was another issue about whether or not TB vaccines or TB drugs would work, given it's the same general area, or is that a myth?
That's all right. The thing about TB, basically not the drug, it's the vaccine. It's called BCG. Now, in Malaysia, if you just ask us to lift our shirt, you'll see that there's a scar there. And that's a BCG vaccine scar. And it's part of our neonatal immunization program. It protects against childhood TB. In recent years, it's been shown again to modulate the immune system. And very recently, it's been used in treatment of bladder cancer. Now, so a lot of people wanted to get into the act. So what they notice is when they look across the board, they said, hey, there seems to be a trend here. Why is the disease rampant in Spain and not so rampant in Portugal? Why South America is not affected, but Ecuador seems to be very. So when they put pieces together and they noticed that the countries where there's high incidence, they had stopped the BCG control program. So this is just a sort of implication, but it's a long way to go. And I certainly wouldn't jeopardize overusing BCG vaccine than what it's intentionally meant for.
Okay, thank you. That's interesting. That was actually the BCG was another question in from Kelvin. So I'm glad you brought that up without me having to raise it. Dr. Tang, could we move back to you, please? I'm looking at a question here which asks specifically, what possible treatments are, what is the likelihood that once we flatten the curve, that the virus will just simply return again? I mean, we're not going to kill it, are we, until we actually have a vaccine? So this idea of personal distancing, social distancing, and so on, do you think that's going to have to continue until a drug is widely available? That could be a year or 18 months. Do you think that's feasible?
Yeah, I mean, looking at the current situation worldwide, because there are increasing numbers of people being infected and from one area to another, from one country to another country. So, and even within Malaysia itself, we can see there are new pockets, new clusters being identified from time to time. So I guess we will have to bear with these measures for a long period of time until vaccines are available, or until a specific effective antiviral available. But even then, even if you were to have antiviral available, it doesn't mean that we will be able to overcome the infection altogether, because, you know, in terms of treating this disease, it depends on the severity of the disease and how patients present. If they present in an early phase, then the antiviral may work very well if there are such good options around. But if they present late, like for example, in a stage 4, stage 5 disease where they need oxygenation support, they need ventilatory support, then with the cytokine storm, then the antiviral alone may not be effective enough. You need additional treatment to counter those effects. Right. So if you continue to have new clusters, new sporadic cases, then that means in the community the virus is circulating. Then you will have problems in eradicating. Particularly if your country is settled, but your neighboring country not settled, or other country not settled,
Yeah.
similar issue will recur.
Okay. Could you just explain, actually, probably for my benefit more, I'm sure other people understand this, but in Malaysia, are we affected by A, B, or C? What is the difference between them? And when we develop a vaccine, as I'm sure we will do at some point, will that be efficacious against all three strains, or do we have three separate types of vaccines?
Okay, from what I gathered, or what DG has told us today, IMR has done virus isolation, and then they sequenced the virus, and they noted that the main strain that they found was B strain, and this is similar to the one from Wuhan or from China. So obviously, they need to do more research in that to see whether the subsequent cases, especially in the second wave, where a lot of people return from Europe or United States, whether the strains is similar. So we don't have that piece of information at the moment. And obviously, if you were to want to have a good, effective vaccine, you need to be able to cover for all this strain, and then to achieve good immunity for the whole community or the whole country. So, I mean, those are quite technical in a way. I'm not the vaccine expert, so I won't be able to say too much about it.
Okay. Well, thank you. Look, I mean, I can see that we're sort of coming up on our time, and I've got a few questions that have come in. Can I just finish off with you, though, Dr. Tan, by asking you, assuming we could have foreseen all of this happening 6 months ago, let's say middle of last year, what should a country like Malaysia, or any country, in fact, have done in order to prepare for this? And is there anything that we've actually learned from this outbreak that will help us to guard against such a thing in the future?
I think the one that we're critically facing shortage is the PPE, the personal protective equipment for frontliners. So we were not quite prepared in that because we never expected the degree of the explosion is so huge and so fast. So to the extent that we underestimated the heat can come in this big way, and really we exhausted our PPE very fast, especially in the Ministry of Health side. The private side, they have been trying to source from various places and various suppliers, and we are still doing so. But you can see if this were to drag on, and if we have one big wave after another big wave, similar problem is going to happen again, and we are going to be we're going to put our frontliners at risk, and that is not a very good thing to see. So that will be something that I think in future we should be more prepared, and also I think in future we should have some special hospital where you only deal with this kind of a huge public health issue outbreak. Like, for example, in Singapore, they have NCID. In Malaysia, we have something similar, but in Sungai Buloh. But it's a hybrid hospital where you are not only treating the infectious diseases, but also you're treating other diseases. So when you come to this big scale of outbreak, you will have to make do with whatever that you have and change the whole setting. Like the Ministry of Health were forced to convert the whole entire Sungai Buloh hospital into a COVID-19 hospital.
Yeah.
So to make it a pure COVID hospital to cater for the needs. So I think for our country in future, we should have similar kind of structure, and to get more prepared for whatever that may come in future.
I mean, I thought that Malaysia was one of the biggest producers of kind of PPE, gloves and masks.
For gloves, but not the others.
Not the others. So
like, for example, we do have N95 being produced locally. So that's one of the most essential item in our PPE list. And the isolation gown, unfortunately, we have very limited supply. And surgical masks, yes, we do have, I think, at least 4 or 5 local manufacturers. But prior to this outbreak, I was told they export most of their product overseas, rather than fulfilling our own local needs. So when things gotten much worse, and we really in needs, we were struggling to source those surgical masks.
Interesting. Okay, thank you very much, Dr. Tan. Dr. Usha, if I could just finish off the last of the first set of questions with you. What do you see the healthcare implications going forward? I mean, has anything good come out of this, do you think?
I think it is laid bare the inadequacies of our healthcare system. I mean, if you just look at across the board, there's something, one of the parameters they say is the number of ICU beds per 100,000 population. So Germany, for instance, has 29, UK has 6 per 100,000, and the US has 40 beds. So on paper, it looks like the US is far ahead. But if you look at, yes, UK may have 6 beds, but everyone in the United Kingdom under the NHS gets healthcare. That's very important. Every person in UK is covered. In the US, with a 360 million population, up to 50 million are left without healthcare. So basically, a lot of money is put into healthcare systems like the States, but it's not put to good, it's basically excessive pricing for drugs, excessive, unnecessary procedures being done. So really, you see, the thing is, this is an epidemic. Why is the world waking up to it? Because in previous problems, we've always been isolationist. So look at the Ebola. In Ebola, we'll say, oh yes, it is Ebola. We feel sorry. We get these vivid CNN pictures. And after that, we go for a good meal because we say, okay, we'll protect ourselves. It is there. It's far away.
Yeah.
But what this opens up is, it's worrying because it requires cooperation. But what do we see? The WHO has lost its credibility. We have seen racialization of the virus.
Yeah.
So if we were to take a step back and say, okay, what positive thing can come out of this? I think if we look at the positives, now we have a clean slate. We have a clean slate and we are able to rewrite it now. So let's rewrite it properly and let's do it together. Now, let's take this for instance. It's brought healthcare to the world. Dr. Fauci is a household name. I mean, forget Dr. Phil, forget Dr. Oz and Drew. So that has brought public healthcare to the forefront. And why are we here today, Mark? Why are we here? We are here because educators, it's a team effort. Educators like you, Emma, Elizabeth, you have built a platform for people like us to give correct information to the public, educate them so that they can make the right decisions. And finally, at the end of the day, this has been likened to the Great Depression. Instead, it is a great lockdown. We can't go on like that. We need money people to tell how do we creatively get out of this lockdown. So we know that, like very quickly, in the recent month, there's been a research in Singapore, Taiwan, when they brought their defenses down. So the question to ask now is, when is the most common question, when is this going to end? I think that's the wrong question. We have to ask, what do we do from here? We have to have an action plan. And the plan is, we have to be dynamic. This is a marathon, it's not a sprint. We have to lift, restrict, isolate, test, isolate, like in Malaysia, isolate the clusters, keep the hot spots, lock them down, let people who can work. So I think this is the only way to move forward. I mean, there is light at the end of the tunnel, I feel.
Thank you. That was a really interesting.
Mark, can I just one last point? Can I just bring up one last?
Please.
It's just something passionate as doctors or healthcare workers that we feel about. I mean, there's been a lot of talk on the internet about when we became nurses, when we became doctors, we went in with our eyes open and we knew what the risks were. We took the Hippocratic oath, we know it's an occupational hazard. But then again, just to compare, when you are an airline pilot or you are a stewardess and you get onto a flight, there is risk. But the airline industry has taken its efforts. They check the planes, you are trained, so much so that flying by air is one of the safest modes of transformation. But my last point is, when I look back at the healthcare system and what its responsibility to the healthcare workers, I have to, with deep regret, say it is just not enough to stand on the balcony and clap. I think we have to relook, and sadly, I think we've failed.
Right. Okay. Thank you. That's a very sobering comment, and I think a lot of people are going to agree with you on that. Now we've got a couple of minutes left. I'll very, very quickly just put a couple of questions out that have come through, if that's okay. One is a question in from Maisie, who's just completing her natural science degree at Cambridge, and she says that that she's been hearing that advice that she's getting is that people should avoid using ibuprofen, but that paracetamol for milder cases is okay. Why is that? Can I just ask that of you, Dr. Usha? Have you heard this, that ibuprofen is being ruled out? Why is that?
Yeah, ibuprofen can be bought over the counter in certain countries. Now, again, it has to do with the ACE2 receptor. And it feels that the mechanism of the way NSAIDs work and in relation to the ACE2 receptor can be detrimental. But these are postulates awaiting further trial. But while it is a postulate, it is best that we treat pyrexia with paracetamol for the time being until further studies are done.
Okay, thank you. I'll just squeeze one more question in. We've got a question from somebody called Burukan Azrina, and she's asking, what advice do you have for interns starting work in the middle of the pandemic? I guess she's talking about medical interns or rather than interns in a law firm. But can I put that to you, Dr. Tan? Any advice for young practitioners who are thinking about getting into medicine right now and looking for internships?
Well, they need to be ready for the infection control prevention measures and know how to protect themselves, especially on the donning and doffing of all those PPE. So that is one of those things that they really need to improve their knowledge on, and also the skills on, so that they when they step into the hospital premise, they know how to use all those PPE to protect themselves and when look after patients. So those are very basic things that they need to equip with.
Okay, I do actually have about half a dozen other questions. Our tentative putative Dr. Kelvin Singh has been bombarding me, but we don't have time for all of those, I'm afraid, Kelvin. I'll put you in touch with somebody else. All it remains for me to say is to thank both of you very much indeed. Emma is going to come back in. I think we have about 2 minutes left. But thank you very, very much for a really informative talk, both of you. Emma, over to you.
Hi. Yeah, thank you, both of you, for explaining some complicated science in accessible ways and for debunking some of those theories. Elizabeth had one on Chinese herbal medicine as well. Yeah, I think it's great to actually hear from some doctors and to be able to have it explained kind of almost face to face. Dr. Usha, you made a very interesting point about the respect that we have for doctors and anybody that's had any contact with the medical fraternity during this crisis is just absolutely in awe, and from their heart is very thankful to you. So I'd like to say thank you very much to Sean, as ever, getting us all technologically together. Thank you very much, great job. Thank you to Mark for moderating once again so calmly and smoothly for us. And ultimately, thank you, Dr. Usha and Dr. Tan, for coming and spending time. I know you are incredibly busy. Dr. Tan's still in the hospital, and we really, really appreciate it. It's been fantastic, and I can't wait to see this back on YouTube so that I can listen again and get a bit more information out of it as well. So thank you. Yeah,
thank you.
Thank you. Thank you. Thank you.
Thank you very much, guys. Thank you.
Stay safe. Stay safe.
Okay. Yeah, and you.
Yes, you too.
Thanks. Okay.